is not really so useful. So I proposed one idea, which is like Cancer Expert Now. I don't know whether you've heard about this, CE in US. So if you put a question, any clinician, you'll get an answer within maybe 10, 15 minutes or half an hour from 3 experts all over the world. So if you can get that kind of real-time, opinion, that's, I think the best thing to happen. Otherwise, what you're doing is wonderful job from NCG. I don't have anything to say. I'm sure this society will benefit as well, apart from ISO. Thank you.
Thank you very much. So, since we are on the tumor board, I'll just trouble Dr. Mittal. I'm sorry we are jumping the line. What about a specialized GI tumor? Because the GI tumors keep coming in rotation once in 2 or 3 months. So would you like to say anything about this initiative of getting a tumor board set up between the NCG using all the facilities of the NCG and the IASG? Would you like to tell the audience something and how you're going to go about it?
So absolutely. I think tumor boards are the way forward. There's no doubt about that. These virtual tumor boards are just the first step in initiating tumor boards across the country. A lot of hospitals don't have any facilities to have a tumor board. So this is the first step towards saying at least once a month we have a meeting. Going forward, I think we have to make it more frequent. You have to make it organ specific, if not, maybe GI surgery, maybe upper GI, HPB and colorectal separately. And then in the near future, we should have every hospital or a group of hospitals should be able to have its own tumor boards in its own town or in its own campus. We have to set a timeline for this, maybe 4 years, maybe 5 years, but that should be the vision, where each of us have access to a tumor board within our vicinity where we can take decisions.
Perfect. And we expect the IASG to start this activity shortly, yes. Send the mailers.
So NCG is taking the lead on it, but as the IASG, we should facilitate it and we should see how we can make it better, at least for GI tumors. How within our hospital network we can set up these tumor boards.
Right. So we will be starting an IASG NCG, which you will be the lead person in, right? Dr. Ramakrishnan, so when you're not running marathons, you're part of marathon surgeries and marathon guideline development. So would you like to add something to the guideline development? And more importantly, there may be a guideline, there might be a system put in place, but how do you ensure that actual good quality care is given? Would you like to comment a little bit upon the guidelines and quality assurance?
Yeah, so there are so many guidelines floating around. So, and most of them are Western guidelines, which probably are not suited to our population. So that is the reason why NCG embarked on this process of developing Indian guidelines suited to Indian situations. Unfortunately, because of a paucity of high-level evidence from India, we still have to rely on evidence from the West, but modify and adapt it to suit our situation. So that was the idea of having the 3 subcategories, the essential, the optional, and the optimal. So like you rightly said, centers that do not have even the essential infrastructure or facilities should ideally not be treating patients with cancer and referring them to centers which have these essential guidelines. Now, having said that, just by having a guideline doesn't ensure that people follow. For example, there was a study conducted from Amrita which showed that for breast cancer, only 20% of the guidelines was actually being followed. There's the NCG guidelines in breast cancer, only 20% was actually being followed. So one of the ways of ensuring that Indian guidelines are followed is what the NCG is trying to do to link the Ayushman Bharat payout with the guidelines. So maybe in the near future, situation might come where you will be reimbursed only if the treatment that you follow is part of the guidelines that is written down by the NCG. So that is one way of ensuring that these guidelines are followed. Now coming to quality, just following a guideline doesn't ensure that you give quality service. So as a pilot project, we initiated a project on developing a quality set of quality indicators in colorectal cancer. So this was a joint project. We had representation from various organizations, including the IASG, and we had an expert team of around 8 members, including surgeons, and also medical oncologists, medical gastroenterologists, radiation oncologists, pathologists, and palliative care specialists, and radiologists as well. So we followed a modified Delphi process, and we have narrowed down to around 16 quality indicators for rectal cancer. Now, this has been circulated to all the member organizations, but unfortunately, we have not got the kind of feedback that we expected. So, I would like to take this platform to request the President and the office bearers of IASG to once again circulate the draft of these quality indicators to all the members of IASG, because ultimately you're the ones who are going to practice it. I mean, so unless we get feedback from the end user, it will be difficult to put that into practice. So once we get the feedback, we can do the modifications. And once we have these final set of quality indicators, we are planning to collect data from whoever is interested. So this is purely voluntary. There is no compulsion that you need to submit your data. But submitting the data will help you gauge where you stand vis-a-vis a national standard. So this is a stimulus to improve your own quality, because ultimately it's the quality of treatment that matters, not following any guideline. So this is what we hope for, and since IASG is part of this development of these quality indicators, I request all the members to kindly respond, give their feedback to the draft that has been circulated, so that we can take it forward.
Thank you very much. So quickly, Dr. Mittal, would you want to make a quick comment before we get some audience questions on database maintenance, collection of data and registries, and how the IASG NCG can help this?
So absolutely. I think all of us have sat through 2 days of this conference and at many other conferences, and almost invariably the first slide that comes is there's very limited data from India. And all of us sitting there know we have huge number of patients. We need a platform where all of us can put this data in, a very inclusive platform where everybody contributes data. We, analyze it, and then everybody is acknowledged and part of that result that comes out, where we can show this is our data and these are our results, and we can compare it to the West, the East, or anywhere else. So as a start for this, there is a colorectal cancer registry being developed as part of a sub-project called the BIRAC project. There are databases being developed elsewhere, and we are working on it. I think we need the help and the backup of the association and the NCG to develop it on the large scale, both in terms of getting members on board and financing it, so that finally at the end of 2 or 3 years, we can have a large database with thousands of patients with good outcomes for everybody who's interested in contributing to this. And that, I think, will put us at an international level.
Thank you. So, Dr. Bhalla, can I have an assurance that all this dissemination to IASG members of NCG activities, these databases, these efforts is going to happen through the IASG mailing list now that we have an MOU?
Yeah, I think that's very much in our interest, and it will and it should happen.
So that will be implemented.
Yeah, and I'd just like to make a point about these guidelines.
Right.
Some years ago, there was a question in Parliament, I think, that they wanted guidelines to be issued upon medical things. So the ministry actually approached many of us and said, okay, you give us guidelines. Those guidelines were made and submitted. We submitted the GI surgery part of it, set of on 8 diseases. They were bound into 2 volumes. They were very elaborately released by I think the Minister for Health. And now they're online. They're available online, but they're just gathering dust. We had a sort of critical appraisal of these guidelines, and 2 points came out which have been addressed by the NCG. One is that guidelines need to be dynamic. They need to be revised. That means you have to have the resources of doing it. And if you have, like I'm told that this is the 2nd edition of the guidelines, which is a very good thing. All guidelines must be dynamic, number 1. So that NCG is addressed. Number 2, it should be authorized. There should be some power behind those guidelines, which also seems to be what the NCG has done. If you're linking it to Ayushman Bharat, and then you say that, okay, we'll reimburse only those that have followed the guidelines, then this can go to the very basic level. And I disagree with the 2 of you that you cannot be referring every cancer patient to a cancer center. Our load is just too much. We have to facilitate the people in the periphery to be able to deliver cancer care according to guidelines which are appropriate for them. I think the IASG has got a great role to play in the GI cancer part of it, and we assure you that we will do what is required.
So thank you very much for that. So the audience, please, now the IASG is linked with the NCG. You are the NCG. Sanjay.
Can I just make one more comment? I think Dr. Bhalla is quite right, and I have to disagree with my good friend Dr. Ramakrishnan. Yes, I think it's not fair to send everybody across to a cancer hospital when we have so much of constraints. We have started off by saying we've got so much of dearth of cancer care facilities. So another idea of NCG is to train people.
Absolutely.
People may not have all that kind of expertise, they may not have all the infrastructure, but with the infrastructure that they have, I'm sure they can do many good things.
Right.
So we have many good surgeons working in peripheral hospitals who are doing equally good job. So the training part is important. They're trying to train, assistants, the technicians. So if you can actually really train people up, you don't always have to send people across.
So Dr. Ramakrishnan's point was, if you don't have the minimum essential facility,
absolutely, I agree,
refer. But if you have it in a district hospital, perfect. So I think that was the point.
I agree.
So I think you all agreeing on the same, same thing. Thank you for that. Yeah, Sanjay.
Yes. Thank you, Sudeep. I just want to start with an experience and then a suggestion for the IASG. So preceding the PMJAY, Maharashtra had a project called the MPJAY, similar project, which was public financing of healthcare. And they set up a quality committee. I was a member of that committee. It was funding surgical procedures. And we tried to drive guidelines through that. There was a health secretary who was very keen. Now, I must say this publicly, that the biggest opposition came from the Indian Medical Association and individual hospitals, including surgeons, because they thought that their, into inverted commas, independence is being... So, for example, there was a guideline which said that you must have a pre-anesthetic, standard pre-anesthetic evaluation. That was opposed. The reason I'm saying this is that if IASG is enlightened, and it seems so because it has foregrounded your talk today in a, as you said, trap between two orations, but still foregrounded it. I think they'll have to look for a route as to how they put pressure on their members. And I think PMJY will do what they want to do. Other insurance will also do what they want to do. The money will push you. But there's one more route which is possible for the IASG, which is to link it with postgraduate training and recognition of postgraduate institutions, which can be a potential route for the IASG. So this is just to put it on the table as a suggestion.
Thank you, Sanjay. I'm sorry, there are a lot of lights here. So
yes, sir. What I'm suggesting is NCG is taking care of all cancers in India. So is it possible that you provide a unique ID for any patient diagnosed cancer in any part of the India, so that there are a lot of patients who are moving around different centers. So one patient diagnosed cancer, he gets a NCG ID, and this ID become unique. He goes to different centers, he has to quote his ID, and you can recognize, yes, this is a patient who started from this place and he got this treatment. So at least this will be like creating registry. Somebody has to send the data to the register to get it entered. So if you have a NCG unique ID, then NCG has a database.
So point number 4, seamless exchange of patient health record. That's what you're talking about.
Yes, sir.
It's there.
I think the government of India is also now trying to come up with a unique medical ID like the Aadhaar, so that like what you said, a patient who goes to another center, you type in the ID, you will retrieve all the medical records of the patient.
I've just been told by the organizers that we can take one more question after, I think after him we might have to close. Thank you.
Right. The most important man, the secretary.
Not really. So, from just assurance point of view, we'll definitely take it forward, that's for sure. But I have fundamental questions which probably take a long time, but just put them out there. I may not have solutions for them, you may not have solutions for them. The basic premise of NCG, to my mind, the way I understood, maybe I'm wrong, correct me if that's the case, that we can't just blindly follow the West.
Yes.
We have to create our own, identify our own problems and identify our own solutions. Problem is, it's a big country and it's a very diverse country. I'm not sure whether I'm sure it's been done, but I'm just putting it out there because this small snapshot may not have captured all you wanted to say, but I'm just putting the question across. Your solution or your problem may not be the problem I'm facing and the solution I need, and so on and so forth. It's a huge country. So one set of problems is, as Sir said, about big surgeons in big places who didn't accept what you said or gradually came on board for whatever reasons can be understated, overstated. Then there's a separate set of people who don't have the same problems, which Dr. Bhalla referred to, small towns, rural areas. So to my mind, NCG is also taking on the task, and this is a fear, or you may call it apprehension, of a lot of members here. They may not voice it. NCG is taking on the task of not only the medical taskmaster, but also the healthcare administrator. And when you take on the task of a healthcare administrator, you also have to solve the problems which the healthcare administrator is supposed to solve. Which means that you will tell me that a small town in Uttar Pradesh cannot treat X, Y, Z, or should
Absolutely.
be doing X, Y, Z. The problem is that doesn't happen. You allow that person to work. You've given him the qualification. And then after that you tell him, okay, now you don't do this, you do this, you don't do this. So there is an inherent clash in between what the science says and what the healthcare administrator says.
Absolutely.
You will have to marry the concepts together and have tiered system of solutions, not have one basket, same
So
solution.
just to quickly answer
That's
that,
what
which is where the essential, optimal and optional comes in. So essential is what the small town surgeon has to do. If he's not doing essential, then the patient is being mistreated. Optional is what your space age facility, robotic science, future science will be. And optimal is what you'll be doing in a tertiary care, SGPGI, or in a big hospital. So in some ways, the guideline is trying. Yeah, so we do, so which is why it's work in progress, and everybody's views are welcome. But there is flexibility. It's not a rigid guideline that this is it and this has to be followed for everybody. So I think that flexibility is inbuilt in whatever little I've seen. So I'm not defending, I'm not the NCG. I'm just someone who is a small part of what has happened, purely honorary. I think it's a great concept and I'm just trying to project it, and the experts and all of you are the actual drivers of the administrative angle of the whole thing. Any last comments from any of you before we wind up?
I think the most important, the first thing is I think we should join the registry. At least people voluntarily, as Ramakrishnan has said, voluntarily we can join. Whoever is willing should join the registry, because that is the starting point. So if Ramakrishna can give us the template or this thing, we can circulate to our members, and whoever wants to join the registry can.
Yeah. So I would just like to quickly summarize. The guidelines are available, the website is there. It's a terrible website, but if you search hard enough, you'll get the information you want. You can see the guidelines, you can put in feedback. There will be a virtual tumor board started soon. Rohin will be in charge of that. The mailing lists will be there, so a lot of this NCG information should come to IASG members in the mail. And all these activities which have been described, colorectal cancer registry, gallbladder cancer registry, all this will be disseminated through emails, and hopefully you'll be able to regularly hear of the common activities between the IASG and NCG. So thank you once again to the organizers for giving us prime time spot, and sorry for overshooting our time. So thank you all of you.